All right, we are just about at 4:30. And so I think we can go ahead and start. I'm going to turn this interview over to Professor Jean Basanta. And Professor Basanta is an emeritus professor here at the SIU School of Law, and I'm very grateful to him for doing this for us today. And of course, we have Andrew Roszak, who is one of our distinguished alum. And so Professor Basanta, I'll leave it to you to do the rest of the introductions and interview. So thank you.
Okay. Thanks, Dean Buys. I am Jean Basanta, emeritus faculty member at the SIU Law School, taught from 1980 to 2014 and taught in the area of health law. A couple things before we start. There will be a question session at the end. This is about a 45-minute presentation and then a Q&A session. What we'd ask everybody to do is if you have questions as we go along, put them in the chat function, and those will come in as you ask them, and then Andy Roszak will address those questions during the Q&A session. I have to warn you, my internet has been dicey the last few days, so I might get dropped from this presentation, and if I do, Dean Buys and Andy Roszak will continue on without me. Without further delay, let's get started. We have Andy Roszak with us, an alum of the law school, a former student of mine. And Andy, I'd like to start off. I think students would find your background and career path interesting. So why don't you introduce yourself a little bit to the students?
Wonderful. Well, thank you so much. It's great to be virtually back in Carbondale. I was actually sitting in the same seats you guys are sitting in, sort of, 15 years ago when I started SIU Law. So it's great to be back and excited to see Professor Basanta again. So my path was a little bit different. I actually started off professionally as a firefighter paramedic and did that for about 8 years before I came to law school, and spent 3 wonderful years at Carbondale. After I graduated law school, I got this wonderful opportunity to become a David A. Winston Health Policy Fellow, and that's a national program. They pick 2 people from across the United States each year to come to Washington, D.C. and study health law and health policy. And was very, very happy. I got the wonderful privilege, thanks to Professor Basanta and Professor Kapp, and was the first Saluki to ever get the wonderful honor. So that allowed me to come to Washington, D.C., where I'd really never been before, and work for the United States Senate during the 110th and 111th Congress on healthcare policy issues. So I graduated in 2008, and that was, as you can remember, back when President Obama was getting elected and healthcare reform was really moving, and just in a really exciting time to be working on healthcare and health policy at the national level. Also, I guess I should back up and say during my time at SIU Law, I was very active with the Law and Medicine Society. I think I was president during my last year there, and just had such a wonderful experience. I helped Professor Basanta write a lot of articles and write for the Illinois Health Policy book or manuscript that comes out every single month from the Illinois Bar Association, and actually had the opportunity to be a legal intern at the Illinois Department of Public Health. So I would drive from Carbondale 3 hours one way up to Springfield 3 times a week and actually work on health policy and health law and public health issues for the Illinois Department of Health. So it was just a wonderful experience. It took a lot of windshield time to drive back and forth 6 hours a day to go to work. But in the end, it was very much worth it. And I don't think I would be where I'm at today had I not made those sacrifices and really took full advantage of all the opportunities that SIU presented me. After healthcare reform passed, I got offered a job at the U.S. Department of Health and Human Services. I was a senior public health advisor in the newly created Emergency Care Coordination Center. And interestingly enough, that was right about the time that H1N1 had started. So the Emergency Care Coordination Center was stood up to help coordinate care, emergent care, throughout the country, and help emergency rooms and paramedics and folks really on the front line of medicine think about how we better coordinate emergency care in this country. So a lot of the stuff I'll talk about today also relates all the way back to those days during H1N1, which we thought initially was going to be a pandemic kind of like we're seeing now. So we've had H1N1, we've had H7N9, we've had Ebola, and of course now we have the coronavirus. After I left the federal government, I was offered the position of Senior Preparedness Advisor to support Super Bowl 46 at a healthcare coalition supporting the Marion County Department of Public Health, and that was in Indianapolis, Indiana. So I did get to have a lot of fun and worked on the Indy 500 and the Super Bowl, which was just really some fantastic experiences, but helping to get the hospitals better prepared. And a lot of the stuff we're talking about today about creating, caches of supply and making sure we have enough ventilators and bed capacity and surge and all this kind of stuff. Even the mortuary side of the house about, if something bad happens, where are we going to put dead bodies? All those kind of things were in play, and we did discuss all that and make plans for that. After the Super Bowl and the 500, I came back to Washington, D.C., and I got a job working at the National Association of County and City Health Officials. And I actually served for 3 years full-time as the Senior Director of Environmental Health, Pandemic Preparedness, and Catastrophic Response. So interestingly, my job 3 years full-time was working with the CDC and the 3,100 local health departments and helping get health departments and communities better prepared for pandemics. So kind of a timely topic. After I left NACCHO, I started working in early child care, and I've been working for the last 6 years now in the early childhood environment, helping to get child care providers, Head Start teachers, after-school programs better prepared to prepare for, respond to, and recover from emergencies and disasters. And it's been really, really rewarding. I've got to do a lot of great things. Last year, I was awarded as a Sesame Street hero and actually got to go visit Sesame Street. And we did a live webcast from Sesame Street about preparing for hurricanes. My work over the last 2 years, I've been working with the Puerto Rico and the Virgin Islands health departments on a contract from CDC to help them recover from those horrific hurricanes that they faced and to make sure our early childhood programs were better prepared and better protected. So that's a little bit about me. I've got a whole bunch of different jobs that I've done. Kind of the continuing theme seems to be emergency preparedness. I really like that aspect of it. And it's a really unique area of the law between emergency preparedness and public health that we get to talk about and not too many people appreciate. But as you can see from the nightly news, it's really at the forefront right now. So here's some collages of all the crazy stuff I've gotten to do. Quite a collage here.
That's great. It's great. Really interesting career path. So let's talk a little bit, if you will, about this COVID-19 or coronavirus, and give us some insights into what it is and what it involves and what a pandemic is.
Wonderful. Yeah. So the term COVID-19 has been thrown around a lot, and so has the term coronavirus. So when we say COVID-19, what do we really mean? Well, CO stands for corona, VI stands for virus, and D stands for disease. So there's your COVID, and then 19 was the year in which it was discovered. What makes this one a little bit unique is this is a novel virus, so that means it's one that we've really never seen before. And that's really what the concern is here, because it hasn't been seen, it hasn't been circulating in the human population. Nobody really has immunity to the coronavirus, and that's why you're seeing just the concern that you're seeing in 183 countries now. So the transmission is person to person. There's been a lot of new information over the last couple of weeks about how this stuff is being transmitted. Originally, we thought it was pretty much you had to be, sneezed upon and then inhale some of those respiratory droplets. But now it seems like the transmission may be even a little bit easier, and there's talk about surface transmission, and we'll talk about some of that as well. The signs and symptoms of COVID-19, and this is a big maybe, because we've got about 50 to 60% of the people that have coronavirus that aren't showing any signs or symptoms, which makes this even harder to detect and harder to really stop. But typically, you're going to see fever, cough, and shortness of breath. Again, maybe. Sometimes about 80% of folks that we've seen out there have mild symptoms, and about 50% have no symptoms at all. So this is a pandemic. What does that mean? This is a global crisis, a global, we think about, epidemics and we think about pandemics. So epidemic is usually limited to a specific region or a country or a series of regions, but pandemic is really widespread. The bottom line is this isn't going to go away anytime soon. There's a very good chance we'll be talking about coronavirus through the end of this year. We do possibly think that maybe this will pull back a little bit in the summer, but then remix and reemerge with the normal seasonal flu. And that's certainly what we saw with H1N1 and in some cases H7N9 as well. We're still learning a lot about the virus, as I mentioned, but it is very foreseeable that 40 to 70% of the entire population in the world may at some point become infected with the coronavirus. So this is very, very widespread, and folks all over the world are dealing with this. So this is kind of a chart that just shows you the different social distancing measures, why we're doing the stay at home and stay away from people and all that kind of stuff. The line on the bottom represents our capacity in the healthcare sector to care for sick individuals. So anybody that has been to a hospital or an emergency room lately knows there's not a lot of excess capacity. Folks are pretty much running at capacity all the time. So the fear is that we are going to see such increase in cases from this coronavirus that it's going to completely overwhelm the hospital and the infrastructure that we have. It is very, very fragile. And this is one of the challenges we have because healthcare is a private industry, as well. And Professor Basanta would always say, they're not going to build a hospital bed unless they can fill that hospital bed, because if they're not at capacity, then they're losing revenue and they're losing money. So from a private sector standpoint, we don't have a lot of built-in capacity in the system to really handle this kind of a surge. And that's really the concern. If everybody gets sick all at once, we're going to completely overwhelm and inundate our healthcare resources, and that's going to lead to a lot more people dying. So when we talk about flattening the curve, we're talking about a lot of people are still going to get sick. A lot of people are still going to probably need to go to the hospital, but it's not going to happen all at once. It's going to be spaced out. And that way the healthcare system can actually handle these cases because everybody's not rushing in at once. This is spread out over time. So if you want to think of a good analogy, think about, Black Friday and everybody that's running into the store all at once to get the deals, how overwhelming that can become, right? So that's kind of what we're looking to do. The other thing that's really interesting about the coronavirus is there's a thing called the R0 value, and R0 is a way to describe how contagious a virus is. And the R0 for coronavirus is about 2.5. So I know what you're thinking, like, Andy, you can't infect half of a person. I get that, and this is based on mathematics and averages and stuff. But the R0 value is 2.5. That means for every one person that gets coronavirus, they could potentially infect 2.5 people. And you can see kind of on the chart here that I've got on the screen how quickly that can add up. Because if you infect 2.5 people and they infect 2.5 people, sooner or later we're going to have a whole bunch of people that are infected, and that's going to again cause that overwhelm of the healthcare system and lead to very bad outcomes. So that's why you're seeing all this push on social distancing. We do know that social distancing does work. Here's a couple of very interesting charts that came out of Italy. So what you see is the cases kind of start off very similar, and this is in Bergamo, and then over in, I can't see the other name because of the things on the way. There we go, in Lodi, in Lodi. So Lodi took a very much more proactive account. So Lodi went on lockdown starting on February 23rd, and you can see how their curve actually did start to flatten after that time. Whereas Bergamo didn't go on lockdown until March 15th, and you can see the rapid incline of cases they had since then. So these are some of the models that early on the policymakers, the public health professionals at the federal government were looking at to try to figure out what our response will be. There was also a really interesting study that came out of Imperial College in London that, quite honestly, it really scared a lot of people. And I think this is really one of the big things that got world leaders starting to pay attention. And what they showed here is that without any kind of social distancing or lockdown measures, they were predicting that 2.2 million people would die in the United States and about 500,000, so 500,000 people would die in the United Kingdom. So when you start talking about, those numbers, that really does get some attention. And you can see all of those deaths were going to occur in a very, very short time within 3 months. So that's why, governments throughout the world are locking people down. Again, we're probably still going to see 40 to 70% of people get infected. But the good news is people aren't going to be infected all at once. It's going to allow the healthcare system more time to be more resilient, more time to care for patients, more time to get more supplies, and hopefully handle the crisis a lot better than everyone just showing up, all at one time. The other thing that I think is important to note about the coronavirus is this is an RNA-based virus. So if you talk about, DNA and RNA and those kind of things, RNA viruses are in the same family as Ebola, in the same family as our seasonal flu, in the same family as Middle Eastern Respiratory Syndrome, so MERS, and SARS. And one of the things that we have to keep in mind about an RNA-based virus is that it absolutely loves to mutate. This is part of the reason why every single year we have to get a different shot for the flu, right? We have to get a flu shot each year because from year to year, the virus mutates. Well, the same thing is happening with coronavirus. And right now, researchers are tracking at least 8 different mutations of this strain that are going around the world. What does this mean? Well, honestly, we're not really sure yet, but it could be one of the reasons that we're seeing higher death rates in some of the countries because of the mutations. That's an open question. There's also a lot of underlying health conditions. For example, in Italy, they tend to have an older population. They tend to smoke more. So there's definitely some underlying health conditions that are considerations too. But one of the things that we're really keeping a close eye on are these mutations. And as we think about a vaccine, and sadly, the vaccine is probably 8 months to a year away still, this is one of the things that everyone has to really keep a close eye on to make sure that it doesn't mutate so much that a vaccine would not be effective. So that's a little bit about the coronavirus. I've got a whole bunch more information over at our childhoodpreparedness.org website in English and in Spanish. So if you want to share that with anybody, please feel free. And we can definitely talk some more. So if you have questions about coronavirus, specifically, we can put those in the chat and we'll get to those at the end as well.
Okay, so with that as background, there's a lot of legal considerations that go into addressing how public health addresses the coronavirus, not the least of which is we live in a federal system, right, with separate state and federal governments and powers and responsibilities of each. And so maybe you could turn to outline for us some of those legal considerations as we address coronavirus.
Absolutely. I think it's very fascinating from a legal perspective to kind of dive into some of this stuff. And I will say some of the health law classes and administrative law and some of those type classes that I took at SIU were of my absolute favorite because they really got into the nitty gritty on this. So the federal government, if you had a true or false question and the true false question said, true or false, the federal government has the most authority in the United States. Most of us would probably say, oh, that's true. The federal government's a big government. They got all this money. They really dictate, what happens in the country. But really, when we think about legally speaking, that answer would be false. And the reason for that, and we'll talk about it, is the federal government is one of limited authority. So most of the health and public health authority that's vested here in the country is actually at the state level. So by design, the federal government actually is very limited in what it can do. The Constitution acts as a limitation of power. So that means we have to really point to explicit provisions of the Constitution to show where the federal government is getting their power from. And most often for public health issues, they do that either through the Commerce Clause or the Spending Clause, and we'll talk a little bit about what those mean. So we talk also about enumerated and implied powers. Enumerated powers are those that are specifically listed. So if you look, through the Constitution, we know that we've got the power to tax and spend for the general welfare. But we also have some of these powers that are like Commerce Clause. And most of the federal health legislation is enacted under the Commerce Clause power. And Commerce Clause, I think it's on the next slide, but really looking at how we spend money in this country, what things are crossing borders, those type of things. So implied powers are those which are necessary to carry out the enumerated power. So for a good example of this, let's talk about the federal authority to do isolation and quarantine. And this became a really big issue in Ebola because by executive order and by the power vested to the federal government, again, the powers here federally for public health issues are very, very limited. Most of that power is reserved to the states. So right now, there's only these particular diseases that the federal government has authority to do isolation and quarantine over. So take a look at the list. You see a lot of stuff that probably comes to mind: tuberculosis and plague and smallpox and yellow fever. And the big one at the bottom, pandemic influenza, which certainly, coronavirus would fall under. But what you don't see on the screen here is stuff like Ebola. So when the Ebola outbreak actually hit, there was a lot of concern about the federal government's ability to respond to Ebola and limit the spread as it was coming back into the country. And what we actually had to do there through the 10th Amendment, and the 10th Amendment says that powers not delegated to the United States by the Constitution are reserved to the states. So that again reinforces this issue that the states have what we call plenary power. They have power that is derived from them to basically regulate health and safety within their borders. So when Ebola was coming back from Africa and folks were traveling to Atlanta or to Chicago or to these big massive airports, we actually had to rely on the local public health authority from the state. So if you're coming back into Atlanta, we were relying on the Georgia Public Health Department. If you're coming in Chicago, the Illinois Public Health Department, to use their powers to isolate and quarantine people. Because again, as I showed you, that's not something that's in the purview of federal officials. This really comes into play as well when we start thinking about cruise ships, because cruise ships are regulated in some way by the CDC. But again, that power to enforce is really a combination between the state government and the federal government. You saw that play out in Florida not too long ago when you had that cruise ship that wanted to dock, and the state officials in Florida were saying no for a couple of days until they finally let that happen. So the state government has very, very broad powers. It has what we call plenary powers. State constitutions and statutes can obviously define that and limit some of that, but they can also choose to delegate powers to locals, and I'll show you what that looks like here in a minute. Importantly, at the state level, we have what we call traditional police powers, and those are to protect the health, safety, and welfare of their citizens. So, if you think about it, there's a reason why pretty much every regulated profession, whether it be a barber, a pharmacy, a lawyer, a doctor, a nurse, a paramedic, we all get our licenses from the state. And that's because of this power that the state has to regulate the health and safety and welfare of their citizens. So, there's not a federal license to go out there and be a doctor. There's not a federal license to go out there and be an attorney. These are very state-specific issues. And when you start playing in the public health realm across all 50 states, you start seeing a whole bunch of different authorities and a whole bunch of different responses. That's, again, one of the reasons why you're seeing so many different states take so many different approaches to these stay-at-home orders. I think there's still, 6, 7, 8 states that haven't issued a stay-at-home order, despite everybody else. I think 96% of the country is on lockdown except for those couple of places. So that is to be expected. That's the way the system is designed. And here's a really good example. So I talked about the state powers, and I said that they could delegate some of those powers to local communities. And you see here in the map that several states, the states kind of in a dark beige or a brown, have actually done so. So if you look at public health powers in Colorado and North Dakota and Montana and Texas, the local public health departments, either at the city or the county level, actually have a lot of authority to practice public health. In Florida, that's a shared example. So even if you work for the Miami-Dade Health Department, you are technically a state employee and you're using powers that are granted to you by the state of Florida. And then there's some states that operate a mix of different powers at the state and the local. And the favorite one is Massachusetts, where Massachusetts, I think the number is they actually have 368 individual local boards of public health. So if you can imagine trying to set a policy, and Massachusetts not that big of a state, but if you can imagine trying to establish a cohesive public health policy with all those different units that could say no or could go their own way, it gets very complex and very confusing. So that's some of the reason why you're seeing different states take different approaches. That's also some of the reason why you're seeing licensure become a big issue, like it does in every disaster. Because while we in our legal system really respect the borders and the different powers and authorities that folks have, obviously diseases, they don't. So that's a little bit challenging, right, Professor Basanta?
Yeah, oh, certainly very challenging. And then with the legal authority that is really divided between state, federal, and as you suggested, local entities, then you have a whole series of policy questions, right, as to how to address a pandemic situation or any public health emergency. So do you want to lead us through that discussion for a bit?
Yeah, so the policy stuff I found just to really be fascinating because it brings into a whole bunch of different, just a whole bunch of different analysis that needs to happen before you can do something. So there's clearly a legal issue, right? So can I do something? Do I have the legal authority to do something? And that's one question. But then we get into the secondary question, and that's more policy based about, should I? Should I do whatever I'm thinking about doing? What is the scope? What is the scale? What's the political fallout going to be? How are my constituents going to react? Is this going to hurt people? All those kind of different questions that need to be answered. And I think this is really some fascinating stuff. So, right now, when we think about the states of emergency, when we think about the stay-at-home orders, when we think about isolation and quarantine and all of these different things, we're trying to balance individual interests and communal interest. And you notice we call it public health. We don't call it individual health. We call it public health because it's really about the public. And, this is one of those cases where, yes, you as an individual can choose to go out and break quarantine or break stay-at-home orders or whatever. And that's really going to impact the public. So you might get sick, but you might not have any symptoms. You might not end up in the hospital, but maybe you get sick and bring that, sickness back to your 90-year-old grandmother, and now she dies because of it. So always a challenge when we think about the needs of the individuals versus the needs of the general public. And you can see kind of this balancing scale that I have depicted here on this slide when we start thinking about it. And you've obviously seen a lot of these play out too about religious freedoms. Is it a good thing to be canceling church? Well, probably. And look, we're here on the eve of Passover. We're about to have Seder dinner in an hour or something. A lot of synagogues and a lot of Seder dinners are going to be very different this year. So, we're starting to restrict individual interests and individual liberties. And hopefully we're getting the balancing right that we're going to restrict those freedoms so much, but it's going to be for the good of the general public. So, a lot of different considerations that policymakers have to think about. I'm sure if you've watched any of the presidential daily briefings, you see the struggle of this, shutting down the entire United States economy and economies all over the world, essentially, so that we can stay in and protect, a few people, I mean, a few 100,000 people from getting really sick and dying from this. So it's a very tough decision. It obviously has political implications. And of course, we're in an election year, so there's even more political considerations as well. So, we know from a public health standpoint that yes, social distancing measures may definitely thwart the spread of communicable disease, but we got to make sure that individual rights are only limited to the least invasive means necessary. And I'll show you some examples of how government actors are doing that. But and there's also been a lot of lawsuits too about what's an essential business and what's not an essential business in this time of shutdowns as well. So when we think about the tools at our disposal, as a public health official, we can impose a curfew, we can evacuate people, we can isolate, we can quarantine, we can restrict public gatherings, you can dismiss schools, we can restrict travel. And we've seen all of these different things play out across the 50 states. Again, some states have done more than others, and that's to be expected. So against all this backdrop, what is the proper policy? How do we balance this? If you remember back in, I guess it was 14 or 15 when we had the Ebola stuff, we did have a few people that came back in and actually had Ebola, and they were put into quarantine, and they ended up breaking the quarantine. And they chose not to comply with isolation or quarantine requests by the local public health officials. One of the cases was actually down in Champaign-Urbana, not too far away. So this is a great publication. I'll put a little plug in for some of my my legal work. You can go check this one out, but it's a really good discussion about isolation and quarantine as a tool to control tuberculosis and Ebola and really what that means. But this is a case where a public health official basically says, you've got Ebola, I want you to stay away from people. I'm going to put you, in quarantine for this long of a time. And individuals say, no, you're not going to restrict my freedom. And lawsuits start flying all over the place, and the legal system and judges have to get involved. And it's a really complex issue. So, even as an attorney, there's so many cool things you can do that you don't necessarily have to be in a courtroom, reading contracts or doing that kind of work, there is a really big need, and there's a great network, the public health law network out there for attorneys that are practicing in public health law and healthcare law. Other things I think are really interesting about just public policy, if you look back from 1960 and 1952, you can see some of the stuff that was out there with cigarettes. And of course, we fast forward now to today and think about how policy has changed. So again, we've always had the authority to restrict these kind of a thing and put warning labels on cigarettes and tobacco products. But my goodness, back in 1960, you could have went out and bought a Philip Morris playset for your child and, had them start thinking about smoking. Other interesting things that we're seeing, again, we saw this in London last year, but we're seeing it now with the lockdowns and the stay-at-home orders. But policy can make a wide difference too. So London had a really interesting initiative they undertook to help curtail the amount of vehicles that were coming into downtown London. And they put restrictions in place to help limit the amount of cars that were sitting there idling. And as you can see, air pollution fell by 1/3 after these emission rules were enacted. So this is an interesting example of how policy can actually lead to better public health. And there's been a whole bunch of studies now about, since we're not driving, we're not on the roads, cities like over in India, they can actually, see the skyline now because all the pollution is gone. So, you always have to be thinking as a policymaker, what are the instant ramifications of my decision? And then what are the long-term ramifications? Or in some cases, what are the unintended consequences of a decision that I make as well? So very, very interesting stuff. Here's an example over in Maryland. This has been a huge debate raging in the early childhood community about the necessity for early childhood. And many states have shut down childcare, saying, look, if we don't have K through 12 schools, if we don't have Head Start, there's no reason that childcare providers should be working as well. Maryland chose to keep childcare programs open. And as you can see, there's an online petition with over 2,300 signatures to get the governor to change his mind. Again, because of the way that the system is laid out, different states are taking different approaches. So the states in the Saluki maroon here on the map have chosen to close their childcare programs, but you see a vast majority of states have actually left childcare open. Same thing here with the incentive programs. So many childcare workers are saying, hey, we're on the front lines of this battle. We're going above and beyond. We're potentially exposing ourselves to the coronavirus. We deserve some incentive payment or hazard pay. And again, through those state mechanisms, there's only 4 states that have actually started to offer people more incentives to stay open. So if you're a private small business, which most of childcare is, you have to really make a decision. Am I going to stay open and try to be economically viable? Or am I going to, close and not risk getting myself or my staff or any of the children sick? And what is that cost benefit analysis? So it's really interesting how you start thinking about the private sector as well. Other healthcare professionals are doing the same thing. You could go pretty much to every national association right now and find maps about the disparate approaches that states are taking. Here's one about testing by pharmacies. So right now, only 5 states have actually changed the scope of practice laws or rules in the states to allow pharmacists to administer coronavirus testing. This map will definitely be changing in the coming days because we know that 95% of Americans live within 5 miles of a pharmacy. And while you can't necessarily get into the emergency room or to see your doctor right now, you certainly can go walk down the street and go into a CVS or Walgreens. This is kind of interesting because, pharmacies are always on the cusp of public health emergencies. They're always there. They're always providing frontline services. They're one of the highest trusted professions when we think about all of healthcare. And yet we never give them this authority except for in times of crisis. So I think a big discussion coming out of all of this coronavirus stuff as we return to some sense of normalcy, whenever that may be, is that, hey, if it's okay to give pharmacists the authority to counsel and test and run these tests in an emergency, why is this something that we're not doing on a day-to-day basis? I think that's a really valid question, and I know there's many different organizations, not just pharmacies, but other organizations that are going to be talking about those issues as well. One last thing on the policy front, this was really interesting with the H1N1. I was involved in a small team of individuals that actually went to the flu.gov website, and we built a web-based self-triage algorithm where you could go on flu.gov and actually put in your symptoms, and it would kind of give you some guidance about whether or not you had H1N1 and whether or not to seek any kind of treatment from a physician or go to the emergency room. And this is the first time the federal government had ever done this. And again, that was back in 2009. And some of the regulatory issues that we had to jump over and some of the policy questions were really just enormous. At one point, the FDA got involved and was actually going to classify our web-based questionnaire as a medical device, and it would actually bring that under FDA for approval. Luckily, because we were working with the U.S. Department of Health and Human Services, we were in the same family, we said, well, we don't want to be classified as a medical device and have to go through that. We just want to provide information to people, again, so they're not running to the emergency room thinking they have H1N1 and clogging up our healthcare system. So it was quite a bit of bartering with the FDA to get us not to be classified as a medical device, which was interesting. And the other big thing, we got a lot of pushback from medical societies that said, hey, if you put this thing out, we're going to come out with a statement that says you are actually interfering with the doctor-patient relationship and you're getting in between that. And we think that this is not only a self-triage message to get out information for people. We think this is actually now you going above and beyond, and you're actually engaged in the practice of medicine because you're trying to diagnose somebody. So, and again, this is when I was working for the federal government. So a lot of these issues really came to bear. As you know now, Apple's got an app out for coronavirus, and many people have, websites where you can go and plug in your symptoms like WebMD and all this kind of stuff. But I'm here to tell you 11 years ago, this had never been done before, and there was a lot of hurdles to getting this ultimately done and ultimately out there. We made the policy decision to limit this to 18 years and older, as we had a pretty significant pushback in doing it for anybody under 18. So just some interesting stuff that you kind of come across that you probably wouldn't expect. It seems like a good idea to get information out there, to get people reassured that they don't need to go to the emergency room and therefore reduce the surge. But it definitely does have some policy implications that come along with it.
Sure. So one of the things that has happened, of course, is kids are home from school, right? Families are all staying home, not going to work, not going out. And in fact, if you look at like BBC News and others, one of the impacts has been a surge in domestic violence. And so there are sort of collateral issues that come in the context of emergencies, right? That need to be addressed. And you talk of that in terms of the continuity concept.
Yeah, so continuity, and this is something in preparedness that we've been preaching for a long time, but we have to start thinking about business continuity and continuity of operations and continuity of government. How are we going to keep everything running? I think a prime example of that is what we're doing right now, and kudos to SIU for having this system and being able to get it up quickly. But continuity of education is very, very important. I'm a professor at Old Dominion University. We're doing the same thing, and we're doing it for not only this semester, but summer semester, and it kind of sounds like we're going to be doing it for fall semester too. So, having that ability to maintain operations during this time is very, very critical. And unfortunately, what we see in the result of every natural disaster or emergency or crisis is that we do see this really has a tremendous detrimental impact on people's behavioral health. So after those horrible tornadoes we had in Joplin several years ago, we actually saw about a 20% increase in child abuse. We saw a 40% increase in domestic violence. We saw an 80% increase in substance abuse and a 30% increase in suicides. And again, this is not uncommon. I told you I've been doing some work in the Virgin Islands, and we're seeing the same things down there after those horrific hurricanes came and really just destroyed the islands. Students in the 7th through 12th grade, 1 out of 12 reported that they'd attempted suicide, and more than 1 in 5 said they'd thought about it. So it cuts across all demographics, it cuts across all age groups, but it's one of the things that we need to think about. And I had the privilege of getting money from the CDC's Public Health Law program. And one of the programs I did with my good friend Tina Hershey, who's a professor up at University of Pittsburgh, is to go out and actually train judges and train the judicial system on disaster continuity and preparing judges for disasters and emergency. So what we would call legal preparedness, because we know that the court system still has to function. As Professor Basanta mentioned, the surge in domestic violence cases right now with coronavirus is unprecedented. And you think about the number of people that are now caught staying at home in environments that are not healthy or environments that they don't necessarily want to be in, but they have nowhere else to go. And that's going to see an uptick in child abuse. It's going to see an uptick in domestic violence and all the related issues. So, part of this job was to go out and actually train judges on public health, what it is, what it does, what they should be aware of. This project also developed a bunch of bench books, which are books that judges can basically grab, and as they're sitting there, they can, flip through and kind of get the cliff notes about what this means and what this does. But really a big part was continuity of operations for the court system, so that they could bring in Zoom and Skype and other innovative technologies to continue to function for the legal system, which is very, very important. An interesting thing, I just got an alert that the DC government all met remotely for the first time ever. The DC Council met this week remotely, and they actually passed a couple of laws. One of them, what I thought was really interesting, was this one here. So they passed a law now that will allow electronic wills. And as you can see on the screen, residents can basically create a will electronically, even over a video chat. This is something that we've never seen before, but a very creative solution. In talking to some of the lawyers that worked for the City of New York, their Department of Law, after Hurricane Sandy, a lot of the law offices in the City of New York for the government were actually located on the first floor in the basement of one of the state buildings or the city buildings. And of course, after Sandy, all of those got flooded. So think about how much paper all the attorneys have and all that kind of stuff. What the City of New York, their Department of Legal Services, started doing to get the recovery sped up is they started actually letting contracts out for folks to come in and rebuild and do repair work. And they were doing contracts just orally. Now they would eventually, take them down and put them in writing, but they realized that they're not going to be able to get back into their offices for some time. So we started doing oral contracts to get the city back up and running again. Oral contract is enforceable, right? So it's these kind of creative solutions that I think that we have to start thinking about. I wrote an article last week about the military and how we may likely see the military have to step in and backfill some local police departments. Right now in Puerto Rico, we have 5 police departments that are shut down. The entire department is under isolation and quarantine orders. They're not serving the public. We have about a fifth of the Detroit Police Department out sick right now. And I was reading an article earlier this week that about 10,000 members of the New York Police Department, NYPD, and FDNY are out sick. So, when we talk about preparedness planning for pandemics, the magic number was always 40%. Assume 40% of your workforce isn't going to show up. And that's either because they're sick, they have no childcare, or they're caring for somebody who is sick. So, as those numbers continue, you may have to see the use of the military to help enforce some of the laws. I'm really concerned about this, to be honest with everybody. I was on a call Monday with some small business leaders in Washington, D.C., and this goes into continuity as well, but we were talking about the unemployment claims. And right now in Washington, D.C., people have had claims filed for 3 or 4 weeks and haven't gotten a dime yet. And they were saying it's probably going to take another 21 days or so before they can process claims. What we have is a really antiquated system of unemployment. They're getting about 10,000 or 20,000 cases that they have to process, and they just don't have the capacity. Further, they didn't think about continuity of operations, so all of their staff are working off of desktop computers, in the city building, which they can't access right now. So when we think about continuity for law firms, when we think about continuity for governments, one of the simplest things that you can do is buy your employees laptops, and that way they can take them home. Another thing that we see quite often is, big businesses will normally cut paper checks and they'll require 2 or 3 people to sign it before it can get processed. Well, that's obviously not going to happen in this time where we're supposed to stay apart from everybody and we can't go to the office and all that. So, these are the kind of things that we think about when we start talking about continuity of operations, continuity of government, and just continuity of providing services to everybody. So it's it's something to be taken really seriously. And I think we're going to see a lot more investment in that, sadly, now, after the fact, than we have historically in the past.
So as a final topic, before we turn to some questions and answers, the slide that you have up now has the word ethics. And of course, there are a host of ethical issues that come up in the context of a pandemic or any form of large public health emergency. The one probably that has garnered most attention is the issue of scarce resources, limited number of ventilators, right? And how do we decide among competing patients who gets access to those limited resources, who gets to be put on the ventilator and who doesn't? And so why don't we talk about that for a little bit?
Yeah, this is a really interesting area as well, and one that definitely attorneys play a big role in. Pretty much, you know, every major healthcare system has an ethicist, as they would call it, and these are experts in looking at these ethical issues. So one of the things that we looked at back during the H1N1 days was there's a law out there called EMTALA, and EMTALA is the Emergency Treatment and Labor Act, and essentially EMTALA started because people were showing up in emergency rooms being asked if they had insurance, and if you said no, you would be put to the back of the line. And we had some really horrific outcomes. In some places, people even died because they weren't getting treatment. So the federal government passed a law called EMTALA, which says anybody that comes to the emergency department has to get screened and has to get basically a course of treatment before you can even think about asking folks for their, their insurance or how they're going to pay or anything like that. One of the interesting ethical discussions that started on this, as we saw back in H1N1 and certainly as we're seeing now, as we start developing alternate sites of care. So a lot of places now are putting tents in their parking lot. They're putting tents up in Central Park. They're building hospitals and convention centers, all these things. What are the implications of EMTALA during a public health emergency? And as we try to keep people separated from each other. So if you have the coronavirus, I don't necessarily want you sitting by or breathing on someone who's just there because they're having a heart attack, or someone's there because they're having low blood sugar and are diabetic. But one of the things that we started thinking about is, can we take all the coronavirus patients and just send them to the parking lot? What happens if somebody actually comes to the front desk and we send them to the parking lot? Well, technically speaking, that would have been a violation of EMTALA, because you have to provide that person at the minimum a screening before you can send them off somewhere to get more care. So luckily we addressed this issue early on. And now when a public health emergency is declared, this is one of the actual laws that the Secretary of HHS, the Secretary of Health and Human Services, can waive. But it brought in a lot of different implications. And certainly in this time of need, we don't want to see people getting turned away for treatment simply because they can't afford it, or simply because they don't have insurance, or in some cases, in some jurisdictions, because they don't have documentation that they're here legally. So this was a big issue. I'm glad that we've taken some steps to resolve it as well. As Professor Basanta mentioned, the other big issue really is the scarce resources. And there's been a lot of effort by the Institute of Medicine looking at crisis standards of care, and what does that mean in a resource scarce environment? Who gets the ventilators, who doesn't, who has to essentially play God and determine who dies and who lives? And lawyers have really been at the forefront of many of these discussions. It's interesting here too, and we've talked about this in the past, but there's a school of thought in the legal system that some of this is actually already baked into the cake, right? So the standard, depending on where you're at and what state you're in, the legal system standard for malpractice isn't necessarily what could you do for this patient if you had unlimited time and unlimited resources. Many times the standard is, what did you do under the situation that you were under, and what would be reasonable, or what would your colleagues or peers do if they were faced with those same dilemmas? So, just from a legal perspective, when we start thinking about issues of malpractice and all those medical concerns, some of these discussions get very, very interesting, because it obviously wouldn't be fair to hold a paramedic in the back of an ambulance in rural Utah to the same standard of a paramedic, you know, in downtown Chicago that's got every resource and has got a trauma center on every corner. Same token now, if you're in a hospital in New York City and you're completely overrun and don't have personal protective equipment and supplies and ventilators, it wouldn't necessarily be fair to hold them to a standard of a hospital that's not being inundated right now, like in Nebraska, that has, you know, 15 nurses on call and 5 doctors and 7 ventilators and all this kind of stuff. So some of this stuff I think is very interesting. I hope that you guys, I'm sure if you take any health law classes, they'll still cover it. But lawyers, again, at the forefront of thinking about standard of care, thinking about these ethical decisions and dilemmas, and thinking about how that's all going to play out. Hopefully we don't have to get there. So far we've been lucky. The numbers are seeming to go down. That's a good thing. People are taking the stay-at-home stuff very seriously. So before we wrap up, I just wanted to give you a couple of good tips and advice here about coronavirus. I think we've beat a lot of these public health messages into the ground, but you know, please continue to wash your hands. That's very important. This virus is very, very weak. The layers of fat and the layers of lipid just dissolve when you wash them with soap. It doesn't have to be antibacterial soap. It can be any soap at all. So wash your hands, 20 seconds is good. Make sure that you're getting in there under your fingernails and in between your fingers. Avoid touching your eyes, nose, and mouth. And this is important because now we're starting to see people say you should wear masks, which I think is a good idea. But the fear is people are going to start putting masks on, and that's going to lead to you playing with the mask and touching your face more than you should. And we know that this virus can be transmitted through your eyes, through your nose, and through your mouth. So keeping your hands down is good. Please stay home for the next few days, next few weeks as this continues to ride out. And if you don't have soap, hand sanitizer can work just as well with 60% alcohol. And also focus on those high touch locations like doorknobs, door handles, light switches, things that a lot of people could be touching. So we'll end on that, and then we'll get into some of the questions if we're able. Does that sound good?
Sounds great, really. Thank you very much, Andy. Really superb presentation. Can you see the chat to get questions?
I gotta find out where I put it. Where did I put it?
Okay. Well, I can see it here. So.
Oh, here it is. Okay.
Okay, you got it?
I got it.
Okay, so why don't you look through, there's some, of course, discussion about housekeeping and other issues for the Zoom presentation, but there are some questions that students have submitted that you might look at and address for us if you would.
All right, so let's look at this one from Samuel. So for those of us whose only exposure to a situation like this is Ebola, how does the virus and the ensuring action by the governmental agencies measure up to other viruses and responses that have taken place in my lifetime? Well, that's a good question. It's a very good question. I will say this has obviously been the most extreme that anybody here has ever seen. Even if you go back to 1918, I mean, and the numbers were horrific. I mean, literally millions of people died during 1918. But 1918, we didn't have the kind of transportation that we have now, where you can hop on a plane and essentially be in London in 6 hours. So the global nature of this and just the speed that information is zooming across the world is really unprecedented. It's really interesting times. I think the government response here has been, I mean, there's really nothing to compare it to. I think it's appropriate. I think the folks are doing the right thing. I think some of the countries that initially thought this was not a big deal or was going to go away. And I will say these are very, very tough decisions for leaders. I mean, you're essentially asking the entire world to stay at home and shut down the world economy. It's not something that's taken lightly. And as Professor Basanta mentioned, there's a lot of underlying conditions that are going to come to fruition. We're going to have mental scars and behavioral issues about this for a long time to come. But I think, this is definitely the first time I've seen the world come together and be much more serious about these issues. I think it's interesting that public health is now finally being kind of thrust in the forefront. Many times public health is very invisible in what it does. So I think it's an interesting opportunity for public health to really shine and show what the value is, and hopefully that'll lead to an increased funding and increased positions in the future. But I also think it's really been a wake-up call. I mean, I could show you papers that we wrote, 10 years ago about these very issues. All these things were known. I mean, we know that we don't have enough ventilators. We know that it was going to be a challenge. But that's the challenge, again, of that private healthcare sector. You're not going to convince a private industry, like a private hospital, to go out and buy 17 ventilators and keep them in a back closet, because they're not going to make money on that. So it's really an interesting challenge as far as, balancing the competing needs of private entities, which our healthcare system largely is, in the public response. And certainly one I think is going to have long-term implications. I also think you're going to see a lot more questioning, as I kind of hinted about. Well, if we were able to waive rules and regulations and allow people to practice across state lines, and I haven't rode the back of the ambulance for probably 10 years, but I keep getting calls, hey, if you want to come be a paramedic again, we'll put you to work. Well, I don't know. I don't think that would be really all that safe. I haven't done it for 10 years, and I don't know how good my skills would be. I'm sure I'd get with it, but I think there's going to be a lot of discussion about rules and regulations that have been waived. And if we could waive it for, 2, 3, 5, 6 months, why are those rules and regulations in place to begin with? So I'm excited for that conversation as well. Let's see. What, if any, legal ramifications would there be if a facility failed to follow CDC guidelines regarding PPE for employees or care and isolation positive COVID patients? That's really interesting as well. We've seen some, I just saw a lawsuit that was filed this morning. I think it was against Walmart. But basically, and you'll obviously learn about all this stuff as you proceed on your legal career here, but basically they're saying, hey, Walmart, you knew this was a problem. The evidence is out there. You didn't take steps to mitigate the situation. You actually put us in danger by making us come to work, and we got sick as a result of it. We've suffered damages, and now we're hurt. And there's been lawsuits filed basically saying that you were negligent in your actions. I don't know. We'll be interested to see how those pan out. I will say that most of the time, or all the time, when CDC issues guidance, again, the CDC is not a regulatory agency, so anything that comes out of them is just guidance. And, you can choose to go above or beyond that threshold. Now, certainly you could introduce that in a court of law and say, hey, this is the guidance that's put forth by CDC and their experts, and that would certainly come into evidence. But the ultimate decision, the ultimate trier of fact, is going to have to decide how much weight to put on something like that.
Okay. I think there are a couple more questions.
Let's see. Illinois recently announced essential workers would be eligible for childcare. Yeah, that's true. We got about 15 states doing that now. I like that model better, because if the state does it, then that gets away from some of these liability concerns that people are seeing. So that's good. You talk about how contagious COVID is. How does this compare to other infectious diseases? So that, that's interesting too. So, the seasonal flu, again, it's different each year. But we normally don't see it, the R naught being 2.5. I mean, normally the R naught is kind of a 1-to-1, or maybe even less than that, depending on the strain. So this is definitely a lot more contagious, a lot more infectious. Ebola is a lot more contagious, but it's harder to get. You really need to have the direct contact, and not the kind of contact that we're seeing here, with the COVID. The other big thing is too, like if you have Ebola, you know that you have Ebola, right? You don't have asymptomatic Ebola. So I think the thing that's really kind of unique and in some ways kind of scary is that we're not really 100% sure how long people are contagious. We do know there's anywhere from a 2 to 14 day incubation period. So you can start showing signs on day 2, day 14, somewhere in between. Or what we're learning is you may have it never show signs at all. So I think, just that particular characteristic of this virus is not something that we're used to. Usually you take your temperature, and if you got a fever, you're considered, contagious, and we separate you. That's not the approach we're going to be able to take here with this virus. So from that point of view, I do think it's really unique, and it's definitely scaring people a little bit more. Hypertension, one of the pre-existing health factors. Yeah, so I think the new prevailing wisdom right now is any kind of underlying cardiac issues. So certainly any kind of immunocompromised. So if you have HIV, if you have AIDS, if you've had cancer treatments, if you have asthma, anything that impacts the lungs. I've seen some studies saying that people that are smoking a lot, because it impacts your lungs, and this virus does impact your lungs quite a bit. Even people that were doing a lot of vaping, you're at higher risk. Hypertension, you know, high blood pressure, diabetes, those kind of things also would be considered high risk at this point as well. There have been some low-cost ventilators invented by some colleges in America. Is the Governor Hospitals purchasing these while they're also searching for regular ventilators? If not, why? Yeah, so I've seen the same thing out there, and I guess it's interesting. It's better than no ventilator, but these are really unprecedented times. And to think that Tesla is basically just producing ventilators, normally the process would be, you know, months, if not years, to go through FDA approval and to have that certification from FDA to say, hey, this is okay, and we know it's not going to hurt anybody. But again, you're seeing all those regulations get waived right now. Part of that waiver, I know there's been a lot of talk about liability waiver, so that, you know, GM and Ford and Tesla and these companies that you're referencing that are trying to do stuff out there in the public good in the heat of the moment without going through the normal regulatory process, have some liability protection. It's kind of like one of these issues with Good Samaritan that you'll talk about in great lengths, but, you know, Good Samaritan protection, basically as a policy, we've decided as the nation that we want people to act. If you see somebody choking, if you see somebody that needs CPR, we want you to act. And we're going to provide those liability protections for you because we think from a policy perspective, that's the good thing to do. That's the right thing to do. So you're seeing a lot of that kind of play out now with these companies that are stepping up and basically building ventilators, building PPE, doing stuff that they never were envisioned to do. But we respect them. We want to encourage that behavior so they're getting the benefit of some of these liability protections as well.
Okay, we've got one more question, and then I think our one or two more maybe, and then we are up at an hour, and so we probably need to wind up because we could go on forever. So you want to, I mean, really, I mean, there's so many interesting issues that get raised. You want to address the one or two remaining questions?
Yeah, so the one's about reinfection. Have there been any cases of reinfection? And that is really, truly the open question right now. And we have seen some data coming out of China. And I will say, you got to be a little skeptical of all the data coming out of China just because the original approach that was taken on this. But I have, yes, seen some cases that they're claiming that people are getting reinfected. And boy, if that's true, that's going to be a game changer because we're really reliant right now in order to open everything back up. We're hoping that once you get sick, you're going to build up antibodies, and that means you're not going to get it again. If for some reason the virus is mutated or if you're susceptible for getting it again, the playbook is really out the window then at that point. So that is definitely something that we're keeping a very close eye on. Let's hope that you can't get reinfected, but it may be a possibility. And then tested individuals can have false positives or false negatives. Yeah, that is true. I will say that the different tests that are out there have different levels of specificity. The nice thing about the tests we're using in the United States is they have a lot higher level of specificity. So you're not in the United States seeing a lot of the false positives and a lot of the false negatives that you have seen in, let's say, France and Germany and stuff, for example. And that's just an artifact because we're using different tests here in the United States than they're using. So there's always going to be some false positives. There's always going to be some false negatives. That's a given with any test. But the tests we're using here are different than the ones they're using in Europe. And the tests here, on average, seem like they do have a higher degree of accuracy. So pretty good. Well, great questions, guys. I really appreciate it. And thank you, Dean, for letting me step in and sharing some of this stuff. I hope this has been helpful for everybody and a good application of how public health is at the forefront. There's a huge role for attorneys to play. And this is just one possible career path that isn't traditionally inside of a courtroom, but really does have a major impact on the health of the country and everybody in it.
Well, thank you so much for doing this, Andy. It was a great presentation. And as I say, there's so many questions that come up. You've done a great job helping us, think through some of those, and there'll always be more. But it's great to see you, and great to see what you're contributing using your education and your experience to really help out. So I think we're done, and hopefully we'll talk again soon, Andy. Thank you so much.
And I'll just add my thanks as well. We really appreciate you doing this, and great questions from the students, and what a great example of where your career can take you. So thanks.
Thank you, everybody. Stay safe, Salukis.
Bye-bye, everyone.